This conference will now be recorded.
طيب السلام عليكم جميعا. مساء الخير للي في أمريكا وصباح الخير للي من غزة مشاركينا. This is a webinar done by PAMA, the Palestinian American Medical Association, about COVID-19. PAMA has been watching the situation in Gaza and West Bank carefully about the COVID-19 situation, which is evolving, and we are trying to be prepared on many levels with our colleagues in Gaza and West Bank. PAMA is doing that on several fronts. First of all, we are communicating knowledge with our colleagues in Gaza and West Bank. Second, we established a network of critical care and ED physicians. We have a group made of US and Gaza and West Bank physicians. We are on daily basis touching base on developments in COVID-19, coming guidelines, and sharing experiences with each other. And this webinar is part of that. We are going to go over COVID-19 information. This webinar is directed to physicians mainly rather than the public. And we will try to provide useful information to physicians who will be taking care of COVID-19 patients. Also, PAMA, just to mention, is collaborating with Gaza and West Bank physicians and officials to provide some protective equipments for physicians, so we make sure that we take care of patients and make sure our healthcare workers in Palestine are safe and well protected. So PAMA is going to launch a fundraising campaign on social media and different platforms to help our people in Gaza and Palestine. With that being said, please join me welcoming our guests here, Dr. Rania Saleh. She is infectious disease doctor joining us from Chicago. Dr. Fadi Safi is a pulmonary critical care disease joining us from Toledo, Ohio. Myself, Majdi Hamashi, I'm a critical care physician in Kansas City. And Dr. Sabir Sarafandi, he is a pulmonary disease doctor from Gaza, and he works at Nasser Medical Center in Gaza. So with that, without any further ado, we'll give a platform to Dr. Rania Saleh. She is going to start the talk, then it will be Dr. Safi, then me, then Dr. Sarafandi. Dr. Rania Saleh, go ahead. I'm going to be forwarding the slides for you. Just tell me next, we'll go from there.
Inshallah. Bismillah. We're going to talk about, as the Dr. Hamashi said, about COVID-19. It's a new emerging virus this year. We know by backward, coronavirus is one of the biggest group of viruses that can cause common cold. We normally tested the ones that showing in the slides here, the one in the green, and they're very common. Again, we see them mostly in the winter time. But going back by the history, every few years, a change happened in the virus genome or the RNA that makes it more, it's a new virus, so it will be highly contagious to the human being, and it will be highly spreading because of the genetic change that they have, so it will be very aggressive. Everybody knows the start of this virus was in China, Wuhan city. They call it SARS-CoV-2 because we have one, I think the SARS-CoV-1 was in 2002 and 3, and this one we have, but this one was the worst from those that we know because it's pandemic and it's all over the world for now. This is more what the virus is contained. It's a RNA. It's not a DNA, and it's one of the largest one. You can go next. This is the pathophysiology, which is I don't really like to talk about, but we probably have to understand it, how the virus works and why all those medications that they're talking about, this help, this may help, this is contraindicated, or it's better not to use. It binds via the ACE2 receptors, and that's mainly in the alveolar cells, and that's why this virus is mainly, it's a respiratory virus, affect the respiratory system. The big deal of it, it's affect big part of the lower respiratory system, and that's why it's called the SARS or the ARDS, and that's mainly the fear part about it, because people, if they're affected badly about it, they will need to be admitted, intubated, and it will be a hazard exposure for everyone too. If we're talking, the expert, they're talking that most of us were gonna get infected at some point, and we will get natural immunity from it. When and how, nobody knows, but it's gonna come soon. And one of it, it's increased the elevation of the CRP, and this is, we really see it. So the cases I have in the hospital, all of them, they have very high CRP. So part of it, the symptomatic one, of course. Next. This is a general talk about types of isolation, which is most of us know. We can add one, but it's not, they're the standard. So the standard, contact, droplet, and airborne. What I mean by standard, which is the hand hygiene. So even if patient is not in isolation, does not have a sign of isolation, you should also wash hands before and after. So this is the standard. That's not included there. The second was the contact, which is mean that you have to wear a gown and gloves, and that's infection transmitted by touching the patient. Let's say if a patient has ESBL in the urine, then if you touch the urine, technically you can get infected by that bug. The droplet is where the infective agent goes from the mouth or the secretions of the body, and they cannot be around that person who's the patients, around them in the air. And the droplets, usually you have to be cautious at 6 feet or 2 meters. So as long as you're away or farther than that, you should be fine. Airborne is different, which is, I think it's the worst, and people are afraid about it, which is the aerosols, they fly in the air, so they can be anywhere. If you have 2 rooms together, they're connected into one system or ventilating system, so that means they can easily move from one room to another. Next. The airborne precaution, which is a big topic here for this, because the CDC has been recommending, if you have the capability to put the patient in an airborne, you have to. I know they mentioned here in this slide that it's mainly if you are trying to intubate the patient or CPR, or you're trying to bronchoscopy, or those like you're manipulating the airways. So that means you're introducing objects into the airways, and you're taking the secretions out, and then you're spreading those droplets around. So that's why you have to be in an airborne precautions. CDC recommends, if you have the capability to do airborne precautions, it's better to put those patients under investigation in an airborne precautions. If you don't, then you just put them in a droplet precaution and not airborne. Next. This is mainly talking about the contact transmission of this virus. So this virus can be transmitted as a contact, droplet, and possible airborne, or in certain situation. The contact part transmission, this is something very important that we need to understand, and that will be more in infection control. And I think this is a big topic in this infection, because this is mainly how we can prevent spreading it. They're still not really sure how long this virus can stay, but they found in the hard, solid surfaces, non-porous, this virus can last even up to more than a week. Even when I was researching it, they were saying up to 9 days or even 10 days. In the air, and I added that part here, it can also stay viable in the air up to 3 hours. This is a question came from one of the physicians or the healthcare. If I'm in the hallway where I have patients with COVID-19, they're in the room, nurses going in and out, you're opening the door, the air comes in and out. Well, this droplet aerosol goes in and out. They can, but they don't last long. They found it could be up to 3 hours. So that's why some physicians or nurses, they like to wear the mask in the hallway. But in the same time, in those rooms, we either droplet or airborne, you keep the door closed. in the old time, even if it's not negative pressure. If the patient coughs or sneezes, this is the worst part, and that's how they come. They're spreading it more. They droplet. They can come to the cloth, to the sheets that they are. If you touch it, then you touch your face, you touch your eye. Any mucous membrane that can go easily and infect or can go do a problem. Sorry. Sorry. Go ahead.
Yeah, and if I may interject, in my hospital, for example, they are asking all healthcare workers to wear surgical mask. They call it like level 1 mask, which is the mask in the OR, the one we are used to wear when we have droplet precautions. So all even wherever you are in the hospital, you should have that mask on. That's a procedure the hospital started applying. I don't know what they're doing in your hospital in Ohio, and that's something for we'll ask Dr. Sarafandi also how they're doing at currently what you do.
Yeah, the CDC. Actually, sorry, you want to go ahead?
Actually, we have a limited resources situation, so we're basically using a surgical mask if there is any precaution. N95 we are using during with the goggles and all the protective PPEs. We are using during bronchoscope or highly procedure, highly suspected patient when are going to intubate. Because of the limited resources only, but basically we have a lot of surgical mask, which is the using in the ER.
Sure, Rania, what do you do?
Yeah. So the CDC says if you have the capability to isolate those patients, if they are confirmed or suspicious under airborne, then go ahead. If you don't, then droplet precaution is fine. Surgical mask is fine. If you have the mask with the shield that cover your eyes, this is preferable. If you don't and you have limited resources, then you just save those to the high procedures, which is, as you said, the bronchoscopy and the intubation. The other thing is when you put those patients in the rooms, let's say you don't have the capability of the airborne, you keep them in the room, you keep the door closed, you try to minimize people in and out as much as you can. The question about using the mask during the time, this is, I think, hospital to hospital policy. My hospital does not have this policy. My colleagues from infection disease, they were pushing to it, and today they were wearing masks. I was not wearing mask. Although I was not wearing mask. So, I mean, I know what to do. So I know what to do, what to touch, what not to touch. We're trying to minimize, and I will talk about that later. That will help you if you guys have more cases. I think by the end of the slides, I will be talking about more about that. You can, let's say if you have an N95 and you want to wear it, you can wear it. You can take it off in and out up to 5 times, as long as it's not damaged, it's not soiled. You can keep it around your face up to 8 hours.
Yeah, and keep it in a paper bag when you take it off. Right.
And yes, we're going to talk about the paper bag later. Yes. And it's important to save the measurements by the nurses. So this is, let's say you have a nurse, the nurse stays 8 hours. Just imagine every time the nurse is going to go in and out, she's going to waste a gown, she's going to waste gloves, she's going to waste a mask. So we've been using those paper bags to save the mask. And the gowns, if they're not sold, the nurse can reuse it. The physician is different. You can reuse the mask, but the gowns not if you're going from a room to a room. I was going to mention something and I remember it now. The issue with the mask, if you're going to go in and out those rooms, because we said about that virus, it may be viable in the air up to 3 hours. So you may be going inside the room, you examine the patient, one of the droplets stuck in your mask, and then you're going to carry it the whole day, and then you might be getting infected. So this is 3 hours, but how many minutes we go inside, how many, so that's
why in my hospital, and not only, I think there's some recommendations are circulating around. And again, it all depends on resources available to each hospital and each country and each city and all that. But they are asking us to put a surgical mask on top of the N95. So when you go in and out, so you get rid of the surgical mask, but you can reuse the N95. But this way you are protecting the N95 from those droplets in the patient's room circulating in the air.
Yes, if you have the capability to use both, yes. But some hospitals, they're running out. So
I'll move to next slide. Fadi, anything you want to add? Anything you're doing different?
Yeah, so yeah, we're doing the same thing as the same hospital as Dr. Rania Hospital. We don't use face mask when we are in the corridors or somewhere else, but the screeners, the people who screen the visitors, we have a limited visitor availability in our hospital, and therefore the screeners who screen the physicians and the visitors, they put the face mask on them and the hand sanitizer. If you have if you suspect any patient with lower respiratory infection, then that patient will have the mask. In the regular rooms, we go by CDC and WHO, which is just a face mask. But if we are doing any intubation or any procedure, then the N95 will be used.
I see. I might be talking about the COVID unit, and we have one unit where we have PUI patients under investigation or confirmed. That's when we keep the mask all the time. So level 3 mask. But okay, next slide. Go ahead.
Okay, this is I think from the CDC. This is just to remind how to wear and what's the steps. The first, you have to put the gown. Then the next thing, you will put your mask, if whatever the choose is, the N95 or the surgical mask. And then the shield, this is the band. So the one I have in the hospital, they have like a sponge with a shield all the way covered. So it covers me all the way. I have a picture, I should post it with you to share it. Or some hospital, they have just like the goggles that they can use, similar to the ones we use for the swimming, the bigger ones. And then the last thing, you put the gloves. After you finish your exam, you finish your interview with the patients, when you go outside, you do exactly the opposite. So the last thing was the gloves. You take the gloves first. There should be a special bags, trash bags or canister to put the soiled gowns, gloves. And then the same for the shield. The shield is something you can reuse. So for me, myself, and we've been educating the nurses. So each one, you go into that unit, they have a shield. We put the name there, we put it in a paper bag, and we save it. So before I start using it, I wipe it with an alcohol. And then in between patients, I do the same. But I do the same with a mask. So if I don't touch really the patients, I don't need to clean it. If I'm going from a room to room, I just change the gown and the gloves. If the patient came to me or I had to touch him, I take it and wipe it with an alcohol. And then, so this is, yeah, I think that's it.
Sure, but that's very important. If we don't follow these steps carefully, as if we've done nothing, like it's very, very important. And some hospitals, they have a 2-person kind of doffing, like you have somebody watching you, what you're doing.
Mm-hmm.
So
yeah, this is our job. Look at me.
Yes, it's like a checklist. So to do it right. Yep. Okay.
Yep. Yeah, this is important for the limited resources. Can we reuse those material? The gowns, definitely for the physicians, I would say no. The gloves definitely is no. This is, I think this is important for the nurses. I think they benefit more from it because the nurse comes for 8 hours or 12 hours shift. So she can have a specific place to hang her gown. The gloves, of course, she has to take off and put a new one. And then the same for the mask. We've been using now, the nurses, they're putting their names in a paper bag and they keep their N95 in the bag. But for the nurses itself, each patient has to have one assigned mask. The nurse, she cannot use that mask because she is touching it. So she's taking it off and she's putting it back. So it has to be for the same patient. So each patient has own same mask. For the physician, it's different. And we revised this today. You can go from a room to a room as long as you're not touching it with your hands. Either you're wearing gloves, new gloves, or your hands are washed. Nothing, should not touch it at all. If today I had to examine the patient, she came close to me, she touched it, I had to take it off, although it was very slight. So this is the best. So this is good to keep in mind. And the same for the surgical mask. So you can use the same thing for both. When to suspect, so the IDPH, or our Illinois Department of Health, and the CDC, they increased the criteria. So I would say 3 or 4 weeks ago, we were screening everyone. Have you been traveling in the past 14 days? This is what the main thing. If they were traveling, did they have symptoms, coughing, fever, shortness of breath? For the past 3 weeks, since the cases increased, we expanded the criteria. And that's why the screening process went up so high. And now almost every patient comes to the hospital with fever, cough, shortness of breath. They have to do CT chest and they screen them. So the suspect is the travel within 14 days. They even extended it to 28 days. So we've been asking, have you been traveling in the past month? Certain exposure. I have a patient in the COVID unit. She said she was in a funeral in Mississippi, and there was one of there was diagnosed with COVID. So she came to the emergency room. We kept her, and then her husband followed her. So we have 2 were exposed to a case. We don't know yet if they are. Exposure means you have to be with that patient or with that COVID-19 positive patients at least 15 minutes. You have to be in a distance less than 6 feet or 2 meters, and you should not wear. So this is important for us, the healthcare. So let's say I saw a patient today, he was fine. The next day he started to have shortness of breath, coughing. Let's say he came with a GI bleed. The next day he started to have a fever, coughing, shortness of breath. They did all the testing. It was suggestive of COVID-19. He tested positive. And then they told me, you were exposed to this patient and you were not wearing the PPE. So I consider to be exposed because I was not wearing it. Then I have to go through the next step, which is self-isolation. The other criteria, which is the symptoms: fever, shortness of breath, cough, chest pressure. I have 4 cases, except one, I don't know, she's intubated, but the other 3, they came with a chest pressure, so it's very typical. And actually, 2 of them, they have GI symptoms. So 2 of them, they have diarrhea, bad. And then the lungs changes in the image. Our ER, they've been doing directly CT chest. They're excited about it, I guess. So they've been putting everyone almost in CT.
Highly sensitive.
Highly sensitive. I have a nice one. I can send it to Mijdi, and they can send it to you with one of mine.
Better than the test.
Nice.
Better
The
than
picture
the
was nice. What's that?
It's better than the PCR. Better sensitivity than the PCR. The CT
Yes.
chest.
Actually, it was not surprise for those patients I have. One is was traveling 10 days ago. He came with a fever, chest pressure, and then coughing, dry cough. His testing, lymphopenia, CRP was above 100, and negative procalcitonin, and CT, very typical picture as we see in the book, or what's been in the book. So, and it was not surprising that he was positive.
Rania, my question to you, which always comes up, is what to do with the CT scan? If you do they clean it after each patient, or what's the protocol in your hospital? That because I advocated for CT scan in our hospital, and they say, you know, we're afraid of cross-contamination, and you know, we need to clean it after each patient.
Yes, that's true.
And how do you transfer
Yes.
the patient? How do you transfer
Yes.
the patient? Do you put the mask and?
They put a mask. Yeah, this is definitely they put a mask. So this is all done in the ER. So when we get involved in those cases, everything is done too late for me to say, yes, this is maybe, maybe not. And then we come the next day, and then you were ruling it out for COVID-19. Not all of them has CT. Some of them have a chest X-ray, and it was very typical. I think that patient, they ended up doing CT just because he was hypoxic. He still needs 5 liters of oxygen. They have. My hospital is an old hospital, but it's a new building. I think it's less than 10 years. And the way they build it for kind of to accommodate disasters. And
nice.
it was after or during the time of Ebola. So they have a lot of capabilities to transfer things around. They're actually now they're switching one whole unit in the emergency room to be negative pressure. So whoever the emergency room doctors and all workers there, they will be all in a negative pressure environment, not just the room. The COVID unit I have is a half floor. Each floor I have is like an X shape. So it's 4 wings. So they switched 2 wings. Each wing is a 20 bed. So that's total 40 beds to a negative pressure.
Wow, that's a
That's
lot.
amazing. That's
Oh,
And they're
yeah.
adding patients every day. Yes, so because the way they built the hospital, they have those capabilities. It was easy. They switched the unit within less than 12 hours.
Wow.
So before I move to next slide, I want to make sure that CAT scan, me or Fadi will talk about it, but in my hospital, we are not recommending a CAT scan in the order set. It's not a pre-check thing. We say, if it's going to change management, do it. If it's not going to change management, don't do it, because doing a CAT scan entails a lot of exposure to healthcare workers who are transporting the patient back and forth. And also, the scanner itself needs to be cleaned, and we need not to use it for 30 minutes after and all that. So it slows things down. Unless I'm looking for like a PE or something different that will change management, I will not do it as long as the patient is under investigation and I'm waiting for the COVID-19 testing, and the patient is gonna be under airborne or droplet precaution anyway, and I will be doing supportive care anyway. So it's not gonna change management.
Yeah. I want to add something, because in working in very limited situation, maybe the CT scan is the only option because of unavailability of the PCRs.
Oh, like in Gaza, for example, like that's
Yes.
what you'll be doing.
I know it's unnecessary exposure, but in our country, we don't have a lot of kits for testing. So maybe if we highly suspect at the initial stage, even if the false negative PCR, CT scan is highly sensitive, almost 97%.
That is true.
That's what we've been doing. We had few cases, they got admitted because of the ground glass. I think my hospital, they have a certain CT for this. Again, as I said, they dedicated part of the ER for this. So my situation may be different, so they have more capabilities, but the IDPH, or the Illinois Department of Health, CT chest ground glass findings is COVID-19 until proven otherwise.
I see. We replace that with any respiratory distress in my hospital. It's COVID-19 till proven otherwise. So we're gonna be, because when it becomes common, and it's an epidemic, to have a low index of suspicion, and the threshold to apply all measures should be low. So that's why we are not necessarily relying on CT. But as Dr. Saber said, Dr. Sarafandi, that every hospital has its own situation, resources, and you will act accordingly. Raina, go ahead.
Yes, so this is a nice picture about the symptoms. The fever is very high, typical for any viral illness. It can be up to 104, 105. One of the patients I have, he was tested March 13 positive. They sent him home because he did not qualify for the criteria for admission. He continued to have a fever with over a week. He came back because the fever is not coming down. And in addition to those symptoms, he started to have more chest pressure. Cough was bad, dry, totally dry. And then he started to have GI symptoms. So the cough in the moderate to severe cases, the fever can last even more than a week. I would say. And the breathing they have, it's more chest pressure. So this is how they've been describing it. They have a pressure inside it more than really chest pain. So you have to ask for a pressure, like the way you have to ask the patient is pressure, not pain. And it's more all over his chest.
I've been reading about this. It's very interesting. It's a pneumonia. It's viral pneumonia, an ARDS, but it is different than other like ARDS patients who have like influenza pneumonia or another etiology of ARDS. And the lung, it's not that stiff. So the lung compliance is not as bad as we expected from the CAT scan findings or X-ray findings. And the PEEP is very helpful, like they are very responsive to PEEP. And that might be why patients are not having difficulty breathing or not feeling it, because the lung compliance is good and they easily take a breath in and out. And that's why there have been reports of silent hypoxemia. Like patients will be walking in the ED, you do the ABG PO2 is 40 on room air and they're fine, like they're talking to you, because they're not feeling that difficulty, and that the respiratory muscles are not loaded, and the work breathing is not high. Interesting.
Yeah, I agree with that. I have that patient on 6 liters. Yes, when you talk to him and you see him, he's fine.
Yep.
His CT chest is more than 50% involved, and he's requiring 6 liters today.
By the way, persistent fever is associated with worse outcomes. So this is something we need to, if somebody still have fever, they don't do well if the patient continue to, same thing as hypoxia.
Right.
Yeah, the other thing we need to keep in mind as any viral pneumonia, when the patient have viral pneumonia for a while, we cover antibacterial because you have all the inflammation secretions that can also introduce secondary bacterial. So the patient who had that for a week, after we introduced the antibacterial, he's been feeling better. So we're hoping hopefully we discharge him tomorrow. Yeah. But we're doing routine stuff for that thing too.
I will come to antibiotics part. That's a timeline of symptoms, Rania. What can you? I mean, that.
Yeah, I'm trying to see it, but.
yeah. It's basically they described I don't know how many cases in this article, but they described the timeline of symptoms. I found it helpful. Again, every patient is different how they're going to present. But interestingly, the rhinorrhea, it came late in the course. Like it's a viral illness, but it's mainly lower respiratory tract more than upper, and the upper respiratory tract features come later. Very interesting, and they come in with cough and dyspnea.
Actually, nasal symptoms is less, and even in H1N1 and in corona. But the tricky thing in coronavirus is low-grade fever, not high-grade fever. This is the most tricky sign because most of the cases they mention in China, they have a low-grade fever. So and the incubation period ranging from 2 to 9 days. So this can give the suspicion, highly suspicion. Other cases, as I mentioned, persistent fever. Dr. Fadi mentioned persistent fever give also a suspicion. Muscle pain and generalized ache and body ache, the most also can give. So it is one of the most common signs. Diarrhea and GI symptoms. Most of them they mention only 2 or 4% only they have GI symptoms and abdominal pain.
Right, it is not
common. Yeah, and I think that is from population because all 2 out of 3 I have, they have bad diarrhea. And 2 of them, they have high fever up to 104. I have the third one has low grade fever. So it's maybe the population.
Right.
Maybe.
But yeah, most reported fever, cough, these are the 2 most common symptoms, and also difficulty breathing, whatever that is, chest pressure, pain as you described, or just difficulty breathing. Okay, and that's a disease course, Rani. I just put that slide together. I don't know if you can tell us about your cases, but most cases from China, they describe patient will be asymptomatic. Then after day 4 after exposure, they will, on average, day 4 to 14, the incubation period, they will have that symptoms, whatever that symptom is, fever, cough, dyspnea. Then 4 days later, they are in the hospital, and then they will like accelerate. The disease will accelerate by 2 days later, a hospital admission, they are in the ICU and they might be intubated. What did you see in your, like you have 4 patients who confirmed COVID so far, you took care of them. Do you?
Yeah, I agree. Most of the cases are either asymptomatic or very mild. We have a lot of screening from the hospital, and most of them are they're at home. So the doctors, they've been calling them, congratulations, you have COVID-19, but they're home and they're doing fine. So this is a lot. The one we have, one is very critically ill. She's a flight attendant. I think she's in her early 60s.
Details, Ronnie. Identify.
No details.
No details.
No details.
No, tell us about the disease.
The disease. Okay. Well, I need to say the difference. She's critically ill, but she's immune suppressed. So that's what was my point, to point that she has CLL.
Yeah.
And that's why she's critically ill because of that. The other 3, they're all, I would say, moderate disease. One of them is just prolonged fever, but I think he's doing well. He hopefully will be discharged soon. The other one is typical from what you're seeing from what they described in China. Once they start to have the symptoms, he's fine. 2 or 3 days, he starts to get worse. And then once they're in the hospital, they may progress and they may end up intubation. And that's, I'm worried about him, to be honest, that he may go into ARDS because his oxygenation is going up. At the same time, he's not feeling much symptoms. He's about the same. So, so we're hoping that he's not going to need intubation soon.
Right. And reports are coming also. The scary part, as me as a critical care doctor in the ICU, and most of you work in the ICU, is there has been a description of those patients who do well and you are weaning them and they might get extubated, then all of a sudden they get worse again. And that is related to myocarditis, critical illness, cardiomyopathy, and some of them, they have cardiac arrest and they go in shock again. And that's very interesting finding, an observation on those patients. It is not the classic ARDS we see. Like our ARDS patients, they get weaned and they just get better unless they have a second infection or something. But that was quite a third of those patients who are in the ICU. Third of them, they have an element of cardiomyopathy, which is scary. So, but that's a disease course in general. The point is, when they get in the hospital, they tend to get worse quickly. And I've been listening to a JAMA, web broadcast today, and a doctor from New York described her patients when they get worse, it's respiratory arrest. Literally, they stop breathing. Like they were fine, okay, being monitored on the floor, and all of a sudden they are severely hypoxic, get worse quickly over hours, to the point they are arresting, and they are almost coding them and rushing to intubate those patients emergently. So their disease is different than other ones we saw.
But those patients, they're minor. They're not all the patients. Not everyone get COVID. He has to be in the hospital, or they have to be. So the majority, they do fine. Yes.
80% do well, 20% go to the hospital, 14% not in the ICU, 4% in the ICU. I'm an ICU doctor, so I talk about the 4%.
This is the only certain percentage, but if that disease progresses and get...
Right. Okay.
So Majdi, the 30% goes into cardiac. They have some element.
The more you will see from those.
Yeah. The 30%, they have some element of cardiac injury, but only 7%.
Oh, I just got back. I think my...
Yes, I will hear you. Yeah, Fadi, to comment in that was an article that was.
I think my connection is slow.
Okay, so I think you're good, Rania. I'm gonna take. I think Fadi or me are gonna take over from here, so you should be good. Fadi, I'm talking about an ICU population.
Yes.
Described nursing home residents who ended up in the ICU. The average age was 70. And those patients were in ICU. Most ended in the ARDS, about 70%, and got intubated. And those patients, a third of them have had an element of cardiomyopathy. So they are a fraction of the 4%, basically, and they are old ones. So yeah, I don't people, it is not a common thing in general, but in the ICU population, it's not that rare. So.
And you can predict who are those, actually. If you measure a high sensitive troponin assay or D-dimer, you can predict who's going to develop cardiac injury. And it's part of, most of the time, it's part of the cytokine storm, the HLH-like picture. So we can use some medications, hopefully, to decrease those. But I agree with you, the mortality will be very high in these patients.
Dr. Safi, you want to take it from here? Talk about labs and take it from here?
Sure. So yes, thank you, Majdi. Thank you, Dr. Rania, for the great introduction. So this is very useful because we use this in our hospital. And Dr. Saber, for you, these things you can use for the best judgment to know which patient you need to screen. So actually, what's going on in our hospital now, in the United States, you will be surprised, but the testing is also very limited. I mean, our hospital, we used to have 7 days sent out test that will need 7 days to come back. So we used to use our best clinical judgment, and we only had the 12-hour or the 24-hour test came to our hospital just today. So for the last few weeks, we've been using our best judgment. So they used to call me, either me during the day or an infectious disease doctor during if they are available at night sometimes.
7 days for the PCR.
We used to have, yes, in the last few weeks, we've been only having to wait 7 days for patients to get, because it was sent out to Mayo Clinic.
It's
Yes,
the transportation. It's not the test itself. It's between sending it out and bringing it back, and how overwhelmed is that center who does the testing. So that's why it takes, because they're loaded. There are only certain centers in the United States.
Because of up to my knowledge, it's 6-hour test.
Yes.
The PCR itself, but the sent out, the process were 7 days. Today we had, our lab was approved because we are in a university hospital. Our lab was approved for all Northwest Ohio. So if you have a hospital which is 2 or 3 hours away, we have to wait. They have to wait until we run the test. So it may take 2-3 days. But what I'm saying is that we've been using the best clinical judgment, and this is what we have. So I used to screen the patient. You know, nowadays we don't use travel, as Rania said, but we look at the other factors. We look at if the patient have lower respiratory tract infection symptoms. We look at abnormal x-rays, and we look at labs. And the labs, you expect lymphopenia. 80% of patients, they have lymphopenia. They said less than 20%. However, what I use usually is absence of leukocytosis. If somebody has pneumonia, which is bacterial, you expect some degree of leukocytosis. But if the patient does not have leukocytosis, then I look at if they have lymphopenia, that increase the mild thrombocytopenia. I find it to happen mainly in the late stages and not early stages. High CRP, as we mentioned before, above 100 is also very sensitive. And then you have the white count, as I said here, normal, the coagulation normal. Procalcitonin is usually normal in these patients. And then what we do, we test them for flu and respiratory viral panel, we call it. If flu is negative, which turn around very quickly, even in the ER, we usually have the results. And the respiratory panel virus. The respiratory panel usually tests for around 8 common viruses, mainly the other coronaviruses, the hepatopneumovirus, and the other herpes viruses and other rhinoviruses. If they come back negative, then that will. But I don't know if that test is available in Gaza or West Bank. It's a PCR test, and it's also could be costly.
We don't have a respiratory virology panel. Yeah.
Do you do the influenza? You do the swab, the antigen testing, Saber? The influenza?
No. We don't have all these stuff.
Okay. Wow.
Nasal swab for virology panel, it's not available in Gaza. Yeah.
Okay.
So next slide is talk about the test. Again, nasopharyngeal swab for non-intubated patients. The sensitivity of this test is low. It's around 60 to 70%. Actually, some studies from China showed around 50%, because the reason for that, as Dr. Majdi said, it's a lower respiratory infection and not upper. Therefore, the nasopharyngeal swab would not be very sensitive. But if the patient is intubated, you need the lower respiratory sample. The Surviving Sepsis Campaign and Critical Care Medicine Society, they recommend obtaining a tracheal aspirate sample without having to bronch the patient. So you can get it in a closed system. I think, Saber, you have that, which is, you put the catheter.
Yeah, we have it, and we did do it for one patient with highly suspect. Deep tracheal aspirate, it is safe and bronchoscope, yes.
Yes, inline suction, easy. You don't have to do. Bronch is relatively risky procedure in those patients. Yeah.
So the other thing we've been doing, Saber, is we stop any nebulizer treatment for any COPD or asthma patients with suspected lower respiratory infection, and we convert everything to MDI. So this is also something to consider, because you don't want to aerosolize the patients, who especially they have some degree of lower infection in this time.
Mm-hmm.
Yeah. Now, PCR.
You are MDI during hospitalization?
Yes. There is no difference.
Hello?
Yes, Sabir.
Yeah. So during hospitalization, we are giving them the MDIs.
Correct.
Correct. Okay.
So, and when we transfer them actually with ambo bag rather than the single filter ventilator, because you know the single filter ventilator, the ventilator you use to transfer the patient does not have an expiratory filter. So you don't want the patients to, infect everything else. So we bag them. That's a closed system, and sometimes we use actually a filter on top between the ET tube and the ambo bag. That also helps to protect the aerosolization.
Good.
So here, we talked about this, Majid. If we can go further.
If you highly suspect a COVID-19 case and the first test came back negative, that does not exclude the disease, and you need to repeat. So, and it tends to be falsely negative, especially if you do it early in the course of the disease, a nasopharyngeal swab, and you need to repeat it if you still suspect patient has it. And if you repeat, you better repeat it in a day or two, like a few days later, and choose another site if you can. Like if they are intubated, now you do a tracheal aspirate. Otherwise, you do oropharyngeal, nasopharyngeal. You try to change the site and do it carefully.
Yes, that's correct. So this is a very important slide, and this is what we talk about a typical X-ray and CT scan. So if you look at the X-ray, all you can see is just core markings, just coarse markings. But when you look at the CT scan, you can see these nice peripheral subpleural rounded ground glass opacification. That's the best description of the infiltrates. So ground glass means, for the physicians, means that you can see behind the lung. It's not a dense consolidation with air bronchogram that you can see in typical pneumonia. So you can see, this is, when you see something like this, it's usually just, we call it usually in non-COVID season, we call it viral or atypical pneumonia. Like sometimes mycoplasma can give you something like this, chlamydia. But in case of COVID, if you have these infiltrates, usually this is highly suspicious. What also they said, COVID-19 does not appear to cause masses, cavitation. I would add consolidation or lymphadenopathy, and imaging cannot differentiate. Or pleural, yes, or pleural effusion. Yes, you're right. So they said if chest X-ray is enough, then you don't need a CT scan. But CT scan, if you can't differentiate, then you have to do CT scan. Especially now that we have some medications that maybe Dr. Rani will talk about them in the future, especially plaquenil and chloroquine and remdesivir and IL-6 antagonist. So actually CT scan can, if the patient has positive CT scan, then you suspect that the mortality will be higher in these patients. And you may need to consider treating them, especially if they have severe symptoms, even if they didn't have ARDS. So the treatment is not only for severe patients, but also for moderate patients with high-risk features, we call it, which is including CT scan features and other characteristics like age, comorbidities, and others. So I'll talk about this maybe in the next few slides. So, okay, this is excellent. So this is management. So supportive care, again, we use this for patients who have mild or moderate symptoms without risk factors. So mild symptoms means that the patient may have fever, chest tightness, some shortness of breath, cough, but he is not hypoxic. So this is very important. So hypoxia is something that you need to look at to characterize the patient. So if the patient satting more than 92% of room air, does not require oxygen, you may even give this patient supportive treatment, just hydration and acetaminophen, and discharge him home. If the patient need admission, like he's hypoxic, if the saturation is less than 92%, the patient need oxygen by nasal cannula, but he doesn't have any comorbidities and the chest X-ray is normal and he turned out to be positive, then you can supply oxygen, supply supportive treatment, and also you don't need to give him any medication. Now, if the patient have moderate disease, so he has like some infiltrates in the chest X-ray, he has a lot of risk factors, which is age above 60, diabetes, structural heart disease. If the patient is hypertensive, if the patient has a history of chronic lung disease like COPD, then these patients you may need to consider other therapy. So you consider oxygen, and then you consider adding them the medications that you have. We usually consult infectious disease to help us with resource management, because the medication, same thing as in Gaza and West Bank nowadays, they are also of limited supply. Now, if the patient continue to be hypoxic or develop severe, moderate to severe symptoms, he's not ARDS yet. Actually, even early ARDS, which is defined as PaO2 over FiO2 of less than 200, but above 100 or above 150. These patients are early ARDS. From the Chinese studies, they treated these patients with high flow nasal cannula in a negative pressure room. And they prefer high flow nasal cannula. And same thing came back from Critical Care Medicine Society, the recommendation that high flow nasal cannula is preferred over non-invasive ventilation, because, and this is none in COVID-19 patients, this is in general for acute hypoxemic respiratory failure, you know, high flow nasal cannula does better in regards to patient hypoxemia management over non-invasive ventilation. So that's the next step, would be a high flow nasal cannula. Now, high flow nasal cannula and non-invasive ventilation can both cause aerosolization, and therefore you need to apply them in a negative pressure room. There came some studies where you have to put a face shield on the patient, where you can cover the whole head of the patient. We don't have these in our hospital. We asked for them, but we didn't have them yet. I don't know what's your other experience with that.
Yeah, Dr.
Actually, by BAB and CBAB, it's available in our hospital, but unfortunately, we don't have the negative pressure HEPA filter rooms. We don't have it, the negative pressure. So it's basically preferring a closed system by mechanical ventilator is safer and less risky than using the non-invasive ventilation and high frequency oxygen saturation. Yeah.
And how about I don't know if you have in Gaza the high flow nasal cannulas, those that you can run the flow at 50 liters per minute. Do you have those available in Gaza?
We have it, yes.
Okay, so those can be really very useful, and you use them as long as you can. There has been some reports with concerns about how high the flow can be on the high flow nasal cannula. Some reports they put a limit up to 30 liters or 40 liters. But going through the recent guidelines by SCCM and European Society of Intensive Care Medicine, they actually did not put a limit. So they say you can use it 50 liters, 60 liters. And if you have a patient with COVID-19 on high flow, you need to have airborne precautions when you go take care of those patients. And preferably, if you have, put them in a negative pressure room, if you have. But
but in our case situation, we don't have the negative pressure, so we should not.
Then you put a mask on the patient.
Right, that is also helpful. Put a mask on. Yes.
Keep the patient with the mask the whole time.
Okay.
Or the whole face cover with the high flow. They have a
I saw a lot of them. The whole face, the whole head cover in Italy. There is also available. Yeah. You saw a lot, but I think we don't have only. We have the face and nose mask, only full face mask. We don't have the
when you
whole
say we don't have them,
head. Yes. Yeah.
Can you purchase them? If there was like a charity like PAMA want to support you with this, is that available to purchase and start?
No, it's not available here in Gaza actually, in the medical equipment stores.
I see. But yeah,
I
so
think they have to be customized.
Yeah,
the whole.
You do nasal cannula, then you escalate care to high flow. If you want to use non-invasive positive pressure ventilation, you should use it for a short time and make sure it's helping a patient is getting better. But keep monitoring the patient. If they don't tolerate it, if they're not doing well, have a very low threshold to intubate the patient. rather
Yeah,
than
yeah, yeah. We have a very low threshold for intubation rather than giving them non-invasively, especially if they are highly suspect to have a corona.
Right. And I put the goal here 92 to 96%. That's what the SCCM guidelines recommend. Keep it in that range because they believe, and literature support, extreme of oxygenation, hypoxemia, or hyperoxia.
More harmful.
Yes. Okay.
Yeah.
So Dr. Safi,
So,
you want to go over the intubation precautions?
yeah, yes, so this is the next. So again, intubation precaution, this is an aerosol generating procedure. Airborne precautions, you need to use, the physician needs to use the N95. And if he did not fit well for the N95, they need to use the PAPR devices. The PAPR, Dr. Saber, do you have PAPR devices in Gaza, which is the device that generates pressure with air, and you wear it like a helmet, and it's connected to a battery?
It's like
no, we don't have it. We don't have it.
So everyone in Gaza will use an N95, and in the West Bank.
We have N95, and the surgical mask and goggles, and most of the personal protective equipments. We have like a donation. Most of these stuff.
We are in PAMA. We are working with officials at the Ministry of Health, trying to purchase some PPEs for the physicians, and some officials in the Ministry of Health mentioned like not PAPR but reusable masks. I think there are 3M masks, and they can be cleaned and reused for several usages, and some of them telling us they can last for 2 months. They are more expensive than N95, but they are durable. So we are looking into purchasing masks for West Bank and Gaza. I will work
in addition, if also video laryngoscope, it will be very helpful also.
Yes. Oh, do you have that? That's the recommendation, to use a video laryngoscope rather than a metal blade.
Yes.
So,
yes.
Do you have that?
Gaza market, the video laryngoscope?
I think we have in some hospitals. We have it. We have them. Yes.
I mean, if a charity wanna donate those for you, like PAMA, do you have them available in the market so we can procure them? We can purchase them for you.
Up to my knowledge, actually, I don't have if it is available in the stores for purchasing or not. I don't have actually any regarding that.
Going for the intubation precautions. So you talked about the full mask shields and negative pressure rooms.
Negative pressure rooms, and then rapid sequence intubation. So you need to hopefully try to paralyze the patient so that they don't generate, they don't cough while you're intubating them. If you want to use a bag valve mask, you need to use a PEEP valve. That PEEP valve will also protect from the aerosol, and also use a video laryngoscope, as we mentioned. You need somebody who's experienced to do it, so that they don't the patient will not have to cough or intubate it more than one time.
If I may add, because I know Dr. Sarfandi, you're going to be intubating, or anesthesia will intubate. Who will intubate in your hospitals?
Actually, our ICU doctors, most of them are having anesthesia background, almost most of them, and they are the one to do intubation and all this stuff. Yeah.
We have in our hospital, we're trying to have, and some other hospitals having an airway team. So that team will be available to come and intubate and go from ICU to another, from room to room. And they will be doing the same thing every time. So you train them on all these precautions and minimize mistakes to null, to zero. And especially that in the US, and I'm sure in Palestine and Gaza, everywhere, all elective procedures were canceled. So we have available staff, anesthesia staff, that are available to help, and they are doing an amazing job. The whole point from, as Dr. Safi said, from RSI, rapid sequence intubation, is to, again, prevent coughing and also to facilitate intubation with using the video laryngoscope. You do it quickly. Now, the point is, if the patient goes hypoxic, what you're going to do, so we are trying not to bag the patient. We don't want to do that bag valve mask ventilation because that's in itself an aerosol generating procedure. We don't want to bag. So reports have been suggesting you apply the mask itself on the patient and you just run oxygen flow and you dial up the PEEP valve to 15 and you just hold it there and hoping that flow of oxygen will inflate the lung and oxygenate for you while you're doing your attempts, hoping it will be one attempt. Another report said, in addition to running the 15 liters through the ambu bag, the whole bag mask thing, you can run another oxygen through the CO2 adapter, 6 liters, which is a post-stem adapter. RT should know that and should be helpful in that, but that was found to be very useful in oxygenating patients. But that's a very tricky time, intubating a patient with COVID-19. That's a very risky procedure. A specialized team should take care of it. If not available, ICU doctors should do that, like mock it, go through it many times before they intubate the patient. Because imagine there is a leak in this intubation. You're going to lose those doctors who are going to be doing the most difficult job in the ICU, intubating patients, and they are the most experienced with the RT. Imagine losing a team like this. What's going to happen to that ICU, the hospital? So that's a very, very critical point.
So that reminds me to say something that we're trying to imply here, and Saber, this can be useful, is that, you know, after the initial contact with the patient and examining or intubating him, and once you isolate and you have everything in order, you can minimize, as a physician, ICU physician, you know, we can do some form of telemedicine. So you can put a camera, that's what we're trying to do, install a camera in the patient room, and then leaving the monitor, trying to leave the monitor outside the room and the pumps and everything, and then try to manage him in like a telemedicine thing. So that's what we're trying to do in the next few days here.
And also, Dr. Saleh and Dr. Sarfandi, I don't know if you're thinking about that. Some ICUs are using long tubing to put the pumps in the hallway. And also,
yeah, I saw it actually. Dr. Fadi put it in his Facebook.
Right.
The pump, infusion pump, they have long tubes, so it's outside the room, so the nurses, they can deal with it accordingly. It is very nice idea.
Yeah, and
it's under the door. We put it under the door. Go ahead, Majdi.
Yeah,
yes, yes.
Telemedicine is gonna be very useful at these difficult times. It has been always useful. I work at the bedside, and I also work in telemedicine, where we monitor ICUs in different locations. So we're gonna be heavily involved with these cases, COVID-19, and we're gonna try to limit frequent patient-physician exposure as much as we can. So by camera in the room and look at alarms and try to communicate with the patient, do what we can. But these are all suggestions that different hospitals can apply, whatever suits them. I keep going for Safi with the supportive care.
Yeah, so that's a nice summary, Majdi. Supportive care, it's like every other ARDS, you need a conservative fluid management. So you need to target a CVP. We used to use a CVP, now we use other measures, but a CVP of around 4. So you don't want to give the patients a lot of fluids, and that came from all the ARDS studies that showed that patients who receive a lot of boluses of albumin, they have worse outcome compared to patients who did not. So that's something. High PEEP strategies is you need a PEEP of more than 10 for these patients, and we discussed this, like the patients will have a ARDS, the PEEP would definitely be helpful in ARDS. You sometimes need to do some recruitment maneuvers, and the recruitment maneuvers should be, you should not do it at one time. You can do it incrementally. and you can apply high PEEP for up to 40 seconds for these patients. A trial of pulmonary vasodilators, so they do not advise using inhaled nitrous oxide in these patients because it's an aerosolizing procedure. So you can use the inhaled iloprost or the inhaled prostacyclin analogs. Prone position for severe cases, actually proning has been found to be very helpful in these patients. And if you want to prone a patient, you don't want to use something where you need to prone in and out. You just need to prone them for around 12 to 16 hours a day. And that came up actually from an EGM study that showed that, I think it was done in UK, they don't have rotaprone beds. We have beds here that they are specialized to do proning, Saber, 2 hours on, 2 hours off. You don't need to do that.
Yeah, it was available in Qatar, actually. Yeah.
It was in Qatar, yes.
It prone the patient, but we can do manually proning.
Yeah, exactly. For 12 to 16 hours, especially if the patient has a PF ratio of less than. By the way, the patients who develop ARDS, the mortality from the China study was very high, 50%. So ARDS, unfortunately, in these patients equal mortality. So you want to target them, treat them very, very quickly. All the medications that you need, if you have remdesivir, you need to use that. If you have the IL-6 antagonist, whatever you have, even steroids, they recommend to use in these patients. And you need them to do high PEEP, prone them, give them some neuromuscular blockade agents to be able to ventilate them. And of course, eventually if they fail, you may need to consider VV ECMO if they don't have cardiac toxicity, but if they do, you may need a VA ECMO. Although VA ECMO has been shown not to work, but it's most of these patients, they don't go into the ECMO and they die, unfortunately, before reaching that stage.
Dr. Sarfan, what do you have and don't have on this list in Gaza hospitals?
Well, I think the VV ECMO, we don't have it. Yeah.
Okay. But
available in cardiothoracic surgery. They can do the VA ECMO in the cardiothoracic surgeon in European Gaza Hospital. I think it's available there.
Oh, I see. And you do proning for ARDS patients. Your team.
Manual. Yes, manual proning. Yes.
Okay. And you use the neuromuscular blockade. You have the train of 4 devices. You do all that. Okay.
Yes.
Sure.
That's good.
How about Flowland? Do you have that?
No, the pulmonary vasodilators we don't have.
Do you have next slide, Najdi, or we are?
Yeah, I think I'll take from here. Take it from here, Fadi. So yeah,
okay.
you don't have the Flowland, right? You don't, yeah, Dr. Sarafandi. Okay.
Yeah, we don't have the pulmonary vasodilators. We don't have it. Yeah.
Okay. So now so what Dr. Safi talked about, this is evidence-based medicine. Like these are approved measures for ARDS, any ARDS patients. We use them, and intensivists, wherever they are, they know what this is. This is kind of what we do on daily basis in the ICU. Dr. Sarafandi does that. Every intensivist who's listening to this talk does this all the time. Some hospitals don't have the ECMO, others do. And again, this is a case-by-case decision to be made. So specific therapies for COVID-19, we don't have lots of evidence. So the whole thing is about 4 months old now. And there have been several trials put together, and some trials are 2 weeks long, others have 40 patients, other 100 patients, and evidence is evolving. So most of these therapies I'm gonna go over, we don't have conclusive evidence. So to mention steroids, for general COVID patients who have respiratory illness, generally it's not recommended to use steroids. So we don't want to use it. And the same for influenza, pneumonia, ARDS. We don't like to use steroids in those patients. But the guidelines have suggested if ARDS is severe and you are intubating and proning those patients, then you might consider steroids for those patients, like 1 milligram, 2 milligram per kg. But also you want to use steroids if there is another indication other than COVID, like COPD exacerbation or refractory shock. You know, we are using more than 2 pressors, and you can use 200 milligrams of hydrocortisone, a continuous infusion or boluses. But the steroids in general is no, unless the disease is severe or there is another indication. Antibacterial, these are sick patients. We want to err on the safe side. We don't want to make assumptions they don't have bacteria and it is a virus. Excuse me. And we should do empiric antibiotic coverage here in all patients. And we then de-escalate care if there is no evidence of bacterial infection on cultures and workup. And Dr. Saleh added also that we should consider antifungal if patient continues to be febrile and not improving after antibiotic therapy also. And whatever we start, it should be empiric, broad spectrum, and we should de-escalate as the cultures show growth or no growth. Fever management. So for any other ICU patient, we do non-pharmacologic and paracetamol or acetaminophen, whatever you call it. Now the NSAID, there is, you know, the WHO put a warning initially about NSAID, ibuprofen, then they took that back. They said we don't have evidence it harms. They put a double negative statement. So it's, and again, in the SCCM guidelines, they say it's debatable. In the Australian, New Zealand guidelines, they did not mention it at all. So what I would say, if the patient is febrile and you did everything, acetaminophen and non-pharmacologic, then you might consider NSAID as long as they don't have AKI or GI bleed or something. So it is case by case, but nothing wrong with using it, especially if fever is very high. Immunoglobulins, like some have suggested using immunoglobulins like IVIG, and there is no evidence to support that, and it might be harmful in terms of aseptic meningitis, renal failure, thromboembolism, hemolytic reactions, and TRALI also. Other therapies, like also like some suggested using the convalescent plasma from patients who recovered from COVID-19. Also, there is no evidence that is helpful. I noticed in the Ministry of Health in Palestine, they suggested that, like, you consider using plasma from recovered patients. That, I think, was mentioned in a document shared by the Ministry of Health, and I'm not sure what's the evidence behind that, but there is no evidence to support it. Other therapies, I'm gonna leave it here to Dr. Saleh to comment on antivirals, and then I'll take it back from there. So Dr. Saleh, you want to comment on available?
Yeah, sure. So that there is, so all of us, we know there is no cure. Those options are to help to slow the process or to block it, to hopefully to help those severe cases. So if the case is mild to moderate, but most of the time we don't do any treatments because mostly they are home. You do nothing. If they have to be in the hospital, you can cover antibacterial. We had a protocol in our hospital based on those studies, but again, we don't know really if they're gonna help or not. If you have a confirmed case and they have certain criteria, mainly the CT chest or the chest X-ray is bad, that's involving the ground glass more than 50%. If they're needing oxygenation or they're hypoxic above, I think 4 liters we have, or 3, and they have no comorbidities, no contraindications for those medication, you can start. The first line of therapy you do is the hydroxychloroquine or the chloroquine. The way we do it is day 1, 400 milligram BID, day 1, and then you downgrade to 200 BID up to 5 days. If the patient got better and he's leaving before that, you don't continue, you just stop it and let them go. Plus minus azithromycin, I think that came up from, because most of the time when you come, when you have see the CT chest or the chest X-ray, the pulmonary will come to me, you have to add antibiotics for this guy. No one will see those chest X-ray and they will not think about adding antibacterial. So most of the time they're from community. You add the coverage community acquired pneumonia, which is ceftriaxone and azithromycin. So this is how they come up with plus minus azithro. Plus, all of us, we know azithromycin has anti-inflammation. So it's not just an antibiotics, it's also anti-inflammatory agent that can help with that. The big problem with it is the QTC. And if they're having, let's say if they're an amiodarone or something like that, the patients, I have 2 of them out of 3, 2 out of 4 they qualify. We put them in a telemonitor to check the QTC. If you don't have that 24-hour telemonitor, you just do daily EKG to monitor that, and then you check the daily liver function enzymes and the kidney function too.
Millisecond, the QTC, if it's more than that, you don't do chloroquine.
Yeah, and again, those treatments are also for certain patients. You should select them very well. You have to have infectious. For us, it's ID restricted. So even the pulmonary, he cannot start it with that. They have to have ID restricted.
Even
harm, even pulmonary, yes.
I don't want that.
Just for you, Mizdi. بس الايديا اللي بدي انا احكيها انه احنا ما لازم نفوكس على انه هذا مريض تعبان كثير اعطيه هيدروكسي ولا لا. الاشياء الثانيه هي اللي بتساعد اكثر. هذه ممكن تساعد ممكن ما تساعد، هذه لما توصل اخر مرحله يعني بالاخر.
And tocilizumab, that was also mentioned because of the cytokine release syndrome kind of a picture, and it mimics the HHL, that hemophagocytic histolymphocytosis picture. And this is tocilizumab, which is a IL-6 receptor blocker, so interleukin-6 receptor blocker. It has been studied. It has shown some promising results in some studies, but again, evidence is evolving. There is no conclusive evidence behind it, and the guidelines did not recommend using it or against it. And the same for interferon. It was studied in previous coronavirus epidemics, and there is no evidence to support its use. But most hospitals in the US, they are putting the hydroxychloroquine for moderate cases to severe, and definitely the antiviral for severe cases. The one you have in the ICU, Dr. Safi, Dr. Saleh, are you using remdesivir or the Calitra? Which one are you using?
Unfortunately, none. She has all contraindication.
Okay.
Yes. She's in CRRT and she has liver. She has multi-organ function. Plus, she's in pressors, and that's one of the big contraindications. So she's.
And Dr. Sarafandi, I talked to you before. You told me that you might have some of these antivirals in Gaza.
Yeah, actually, we have our protocols. We're using Tamiflu and azithromycin. We have also the ribavirin. We have interferon, big interferon actually. We put it in our guideline, the leponavir or Calitra, but actually until now it is not available. Maybe we will ask it from WHO. We categorize the patient symptomatic, asymptomatic, symptomatic to a high risk group, or there is no risk. The high risk group, we start them in Tamiflu, and in addition to the chloroquine, we don't have a chloroquine, we have the black quinine, hydroxychloroquine. Also, but we have also the caution, very caution to QT interval regarding hydroxychloroquine, especially in elderly patient. The high risk group, we categorize them to the age more than 60, patient with the heart failure, renal failure, chronic kidney disease, chronic lung disease, immunocompromised, diabetic patient. All these, they have a high risk group. Even if they are asymptomatic, we start them in the Tamiflu in higher doses in addition to the hydroxychloroquine and zithrocin. Yes.
We use Tamiflu because you do not test for influenza, so you don't know if they have it or not. So you just empirically.
We don't have, we don't have a virology panel. We start them empirically, yes.
It's interesting how
you said asymptomatic. Why you would do treatment if they are asymptomatic?
Actually, we did the committee, and we found that it is most of the guideline. If the patient is asymptomatic but he belonging to the high risk group, we just start them in the Tamiflu and hydroxychloroquine.
Okay, we have the opposite. So if only the moderate to severe or the ARDS. That's the only one.
This is according to our protocol, but recently we are making more cautious because the patient is we have also actually documented 2 cases. Most of them are elderly, so we are cautious about the hydroxychloroquine and the Tamiflu. If they are asymptomatic, and alhamdulillah they still asymptomatic, they don't have any symptoms, only just risk factor by the age, so we don't start them until now.
Yeah, Tamiflu, I agree. Hydroxychloroquine, I would be careful because they have symptoms. There's no need. But Tamiflu,
we start. Yeah. This is actually what we did.
Good.
So
we started like this, then we changed the protocol.
So
go ahead, Mitch.
Yeah, this is again, we were talking about that throughout the slides since we started. So this is not an totally inclusive slide, but these are some of the prognostic poor prognosis predictors for those patients who you might want to be careful, monitor them closely, and expect that they might worsen. Old age, as we know, the mortality goes up with age, comorbidities, coronary artery disease, hypertension, diabetes, and chronic pulmonary disease, worsening and persistent lymphopenia, and also neutrophil to lymphocyte ratio more than 3, persistent fever, as Dr. Sarafandi, Dr. Safi mentioned, and also increased inflammatory markers, also high troponin and any cardiac dysfunction, that's a poor prognostic factor, and so on. And and also CT scan findings, you can add that. And several of those have been compiled into a severity index kind of score to guide antiviral therapy, when to start them and all that. So
actually, we categorize the patient also in asymptomatic and symptomatic. Symptomatic with upper respiratory tract infection only, and symptomatic with pneumonia, with confirmed by chest X-ray or CT scan, and symptomatic also with severe pneumonia that requiring ICU admission. The category we are using CARB 65 pneumonia severity index. And in addition, if they enter the ICU, the PF ratio less than 100, 200, 300 accordingly, yes.
And I noticed also, I'm going to give back to Dr. Safi to go over the last 2 slides. But before that, I saw a document by the Minister of Health, Dr. May Cayley. I saw her name, like signing it, blessing it. I think it's a very good document. I went over it. I put my comments on it. I don't know, like few of them, I don't know if I can quickly go back to them, but it's a very good document. I just mentioned now the using the plasma from recovering patients. I'm not sure about that. I also, a few points on it, but generally speaking, it's a very good document. So you might, but it's not an order set. I encourage everyone in Palestine and Gaza to take that and change it to an order set. An order set is kind of a more practical way. When those patients come in, you have set of orders, you're going to order them. So you and the nurses and colleagues and everyone are on the same page, what you are planning to order and follow on. Dr. Saleh?
Yes.
The last 2 slides are yours.
طيب هذا الموضوع كتير مهم، لأنه إحنا بنحكي عن اللي راح يصير أو المتوقعين إنه إحنا يصير، بس هل هذا لازم يصير؟ إنه مش فينا إحنا نشتغل على هذا الموضوع. أعتقد هذا the most important اللي هو infection control. And I know you guys started the process. You're trying to identify cases. You guys trying to isolate them, not to spread. The same is for the hospital. The employees, all of them, they have to screen themselves, checking temperature at least once or twice a day. If those employees, any of their family member are sick, they should not come, they should call sick. And also try to use the mask if you have to, avoid unnecessary. So it's more infection control management, prevention, because I think this is the best you guys can do now, and you guys in the beginning. And it's not easy, but it needs everybody to be involved and take things serious from everyone. If you are outside if you're in a crowded place, you should not go in there. I don't know if they أعلنوا عندكم إنه lockdown إنه يخففوا الناس برا. I think في الضفة they already started this. بس بعرفش بغزة.
دكتور صالح حمدي في غزة عملوه ولا لسه؟
Well, we are asking for the lockdown since almost two weeks, but until now, they in the mosque there is there is a lockdown. In the mosque there is no Jum'ah prayer. Also, until now there is no general lockdown.
About schools, are there schools for Gaza?
No. There is no schools. There is no schools since 1 month. There is no university. There is nothing. Yeah. Most of the ministry they are not working. Yeah.
Well, I like what the West Bank did. You know, everything is now shut down. Everything.
Yes. Everything is shut down actually because it is very limited the spreading of the infection. This all these measures help in limiting the spreading of infection. Also because until now the key is flattening the curve. Because if we are overwhelmed with all cases, overwhelmed with a lot of cases, so our healthcare system will not tolerate any more patients. So the general lockdown is very nice, and in addition to that, also we don't have any other resources. If we reach the acceleration phase of pandemic, it will be a disaster.
That is true, and PAMA has been watching that situation closely. And you mentioned a very important point. We should have covered that with a graph, which is flattening the curve. What that means, if I want to say it one more time, Gaza is expecting 2,000 cases. They are preparing themselves for 2,000 cases in Gaza, and they expect that 400 of these are going to end up in the hospital, and 100 will end up in the ICU. And yes, those cases can happen over a period of 1 week or 2 weeks.
Yes,
and we don't want that to happen. We don't want that peak to happen. We want to flatten the curve. We want those 2,000 cases to occur over like a month or 2 or 3, so the 100 patients will not end up in the ICU at once. We spread them over time, so the health system will not be overwhelmed, especially in Gaza with limited resources. That would be a disaster, as you described.
Yes.
And by the way, this 2,000 is if people still like isolate themselves. If they didn't isolate, you don't know how much the number will be.
That is true.
Yeah. Yes, we don't know actually. We have a lot of ignorance here. The people, they don't know the problem is, so they still going there chopping and playing. They don't have any idea about what they are going. So the general block down is very important, and it's very studied the measures which happen in Wuhan in China. This is the general lockdown. The military they interfere, so they reach the decline stage very safely. Here, our job is just we need to slow down. We don't need to reach the acceleration phase. If we reach the acceleration phase, so we will see what's going in Italy and Iran.
So before Dr. Saleh go to the last slide, and that's a good chance to يعني أن أوجه كلام حتى بالعربي للناس في غزة، الناس في الضفة، إنه هذا المرض معدي جدا، ومش شرط بيصيب الكبار بالسن، عادي يصيب الصغار بالسن برضه، ما في حدا عنده مناعة منه، ولا سمح الله إذا بعض الناس عادي يموتوا من هذا المرض. الناس لازم تدير بالها، تضل في بيوتها، مهم كثير تضل في بيتك حتى الفيروس يعدي ويخلص ويروح وينتهي بدون ما يصيب ناس كثار. السلطات وين ما كانت في غزة ولا بالضفة ما تمزح في هذا الموضوع. كل شيء المفروض يتسكر، الحركة تتسكر، الأسواق تتسكر، المولات تتسكر، وقفوا صلاة الجمعة، وقفوا أي حشد جماهيري، كل الناس تضل في بيوتها، وحتى قوى الأمن والشرطة تنفذ هذا الكلام، إذا مش يعني بأي وسيلة. هذا كلام كثير مهم، خاصة في بلد ما عندوش ريسورسز تتحمل الأزمة إذا صارت. فهذه إحنا رسالة بنوجهها. طبعا أكيد ما شاء الله إحنا بنتابع الأمور فلسطين، الوعي عندهم فوق العادي، وأنا انتبهت إنه الوعي في فلسطين وغزة والضفة كبير، ووعي الناس والأفراد والأطباء متعلمين جدا وبيعلموا يعني الآخرين. فإحنا بنشد على ايديهم ونحكي لهم هذا كلام كثير كثير مهم.
دكتور صابر، الريستورانت، المطاعم والمقاهي فاتحة ولا سكرت في غزة؟
والله المطاعم لحتى الآن المطاعم شغالة، أغلقوا الأسواق العامة. احنا عندنا في غزة يعني مثلا في كل مدينة في يوم سوق عام للجميع، يعني الناس بتيجي وبتبيع أغلقوها، أغلقوا صلاة الجمعة حاليا. بس ما عملوش يعني منع تجول، يعني ما وصلناش لمرحلة منع التجول. اللي بنشوفه بعض الاحيان في ناس في موجودين، يعني بتروح في اي مكان بتلاقي في يعني حركه كثير. الناس في بعض الناس برضو عندها استهتار، يعني واستهتار كثير، يعني بتلاقيهم بروح وبيجي، هذا ما بدركوش حقيقه الوضع. هلا اللي فاتنا احنا هنا في قطاع غزه، احنا تحت حصار تقريبا، البلوكيد او السيج هذا صار له تقريبا 14 سنه. فوي دونت هاف، مع الناس سياح، ما حدش بروح ولا حد بيجي، فاحنا وي هاف ليميتد الناس اللي بتروح ولا بتيجي. هذا فادنا لمرحله كبيره. من 15/3 اعلنوا انه هو اصلا اللي هو الحجر الالزامي. كان زمان اللي هو الحجر المنزلي الذاتي، هلا الحين الحجر الالزامي من 15/3. فاد كثير. we picked up 2 cases now, they came from Pakistan. والحمد لله يعني حتى هذه اللحظة الأمور تحت السيطرة. أنت عارف اللي هو الفيريولنس تاع الفيروس وسرعة الانتشار، هاي مشكلة كبيرة يعني. الشغل الشاغل الآن اللي هو يعني عدم الوصول إلى مرحلة التسارع، يعني تبطيء الوصول إلى مرحلة التسارع، لأنه إذا وصلت مرحلة التسارع المشكلة بعدين.
طب احكي لنا، في 21 مركز حجر صحي في غزة، وفي حجر ل 1900 مريض مشتبه في أعراضهم.
نعم. هذا من 15/3 كان هنا في حجر إلزامي. أي واحد راجع عن معبر إيرتس ولا معبر رفح، حجر إلزامي لمدة 14 يوم. لمدة 14 يوم، نعم. وأي واحد تظهر عليه أعراض بصير. طبعا إحنا عندنا في بوليسي من زمان يعني موجودة، تعريف الحالة. أي واحد عنده history of contact، مخالط، راجع من السفر، عنده أعراض اللي هي موجودة اللي ذكرتوها، هذا بيعتبر تطبق عليه تعريف الحالة أو case definition. بيصير عنده إجراءات معينة، بيعزل في المستشفى في مناطق الحجر، وبيتاخذ منه سواب فور PCR، واذا طلع نيجاتيف بعديها بصير يعني هم يعني. بس اي واحد بيرجع الحين على قطاع غزه يحجر حجر الزامي لمده 14 يوم whatever he is coming for. Even the patient they isolate them in the hospital.
شفت كمان في مركز حجر صحي عم ينبنى، ايش هذا؟ بيبنوا شفت مبنى يعني عم بيبنوا بغرف وبحجر صحي، بتعرف؟
مش عارف والله انا هذا، بس يعني بالنسبه له هذا بالنسبه للطب الوقائي انه في حجر، يعني الناس اللي حييجوا في غرف الحين مهجوره، لانهم الحين الحجر في بعض المدارس، في حجر موجود في بعض الفنادق موجودين. فاكيد الحالات طبعا اللي بيرجعوا كل يوم والثاني بيرجعوا على قطاع غزه، فبيقدروش يعني انهم يعني في اماكن هذا، فهم الحين بيبنوا غرف لهذا الحجر الالزامي طبعا.
نعم. الدكتور صالح بدنا نكمل معك انه just to mention انه في هون avoid unnecessary procedures bronchoscopy, CT test, nebulized medicine etc. unless يعني CT scan you need to rule out another diagnosis, follow intubation precautions. This last slide by you Dr. Saleh and we're gonna be done.
هذه أنا حطيتها لأنه زي ما اللي حكينا شيء مهم اللي بتعملوا أنتوا كتير منيح، اللي هو isolating و early detection. هلا يفضل إنه إذا صار بده يصير حالات أو إن شاء الله ما بيصير، بس إنه يكون عندكم emergency plan، يعني إنه يكون في مثلا مستشفى معين، فلور معين، طاقم معين، هدول بس إذا في حالات مشتبه فيها يكونوا في ناس معينين في منطقة معينة هم اللي بدهم يتعاملوا مع هدول المرضى. to limit everyone. حتى إنه مثلا إذا اللي بده يعمل ياخذ الدم يكون أشخاص معينين، اللي بده ينظف المكان بيكونوا أشخاص معينين، المساعدين الممرضات، الدكاترة، كل السسبكت كيسز بيروحوا هاي once you roll them out بتطلعهم على الريجولار فلور أو شيء. you have to involve a lung doctor أو pulmonary doctors. إحنا الكرايتيريا عندنا if they need an oxygenation or if they have respiratory compromised symptoms, you can involve the lung doctor. But to rule it out, you don't have to have an infection disease or you don't have to have a pulmonary. وقد ما فيكم إذا suspect case إذا فيك تروحوا على البيت روحوا. فيك مثلا تخصص طاقم مثلا إنه يراقبوا المرضى من البيت. يعني مثلا ثاني يوم الدكتور أو ممرض يتصلوا على المريض أو على أهله إنه كل شيء تمام، المراقبة من بعيد اللي هي زي ما حكى الدكتور مجدي اللي هي التيلي ميديسن. إحنا كمان بلشنا نستعملها. أنا برضو بعمل تيلي ميديسن في infection disease قبل هاي، وإحنا هلا عم نستعملها بزيادة لأنه المرضى اللي بنيجي على العيادة ما فينا ناخذهم. المرضى اللي اوريدي اللي عندي confirmed case و suspected case بنحاول ما نعبر عليهم قد ما فينا، واحنا عندنا ريسورسز اكثر. فهذا شيء مهم. فقد ما فيك تروحهم على البيت روحهم على البيت، ما تخليهم بالمستشفى.
ممتاز. Any questions from any of you or comments? Dr. Sarafandi, anything you want to add?
Actually, it's perfectly يعني information, but I have to add. بدي أضيف الحين حاليا في بيت لحم وفي عندنا كمان إنه شكلين تيمز عشان ما يخسروش أي تيم من هذا، إنه 14 يوم يعني التيمز اللي بتابع المرضى في مستشفى الحجر اللي هو مخصص للمرض هذا بتابعوه for full 14 days، بعدين بيعزلوا حالهم 14 يوم وبعديها 14 يوم إجازة. فهذه it is very very effective idea موجودة حاليا started من أول ما اكتشفوا الحالات في بيت لحم من 14 يوم، وامبارح أعتقد غيروا التيمز يعني جابوا تيم تاني ل 14 يوم. فهذه it is very effective و isolating عشان إنه not to expose all the teams for high risk، لأنه إذا في المرحلة هذه خسران أي موظف في الصحة هيكون خسارة كبيرة يعني if they got infected.
Sure. Dr. Safi, anything you want to add?
شكرا جزيلا مجدي. ان شاء الله بس نتمنى السلامه لاهلنا في غزه وفلسطين ضفه والجميع ان شاء الله، وان شاء الله نسمع عنكم اخبار طيبه دائما. صابر والجميع.
امين امين. ربنا يحفظ فلسطين وكل الناس ان شاء الله يا رب.
صالح, anything you want to add?
لا شكرا.
Well, thank you, Dr. Saleh from Chicago, infectious disease doctor. Dr. Fadi Safi, pulmonary critical care from Toledo, Ohio, and Dr. Sabir Sarafandi from Gaza, from Nasser Hospital, and myself, Majdi Hamashi, critical care in Kansas City. Thank you very much. PAMA will keep a close eye on Gaza and West Bank, will help with whatever we can. And inshallah, Allah يسلم فلسطين وما نشوف ولا حالات كمان، وهذا هو إن شاء الله يا رب الجميع. شكرا لكم جميعا. شكرا.
شكرا.